And now we have oral diseases with immunologic pathogenesis. So what does that mean? Well, these diseases are not fungal or viral. They don't have to do with bacteria, but instead involve the body's immunity system, the body's immune system. So it's getting an oral disease in your mouth, not from a virus or from fungus or from bacteria, but instead from your immune system. So, autoimmune diseases. The immune system learns to differentiate between foreign and self tissues. The autoimmune disease, in autoimmune disease, the recognition mechanism breaks down. So remember, in your immune system, your body can recognize antigens or threats. In autoimmune disease, your recognition ability breaks down. You can't recognize what's a threat. It can affect single tissues or entire organs. For example, T cells often attack the pancreas in diabetes type 1, which is why your pancreas can no longer make insulin. So these are the types that we're going to talk about. So aphthous ulcers. Aphthous ulcers are painful with unknown etiology. So we don't know how they happen, we just know that they hurt when they happen. It occurs in 20% of the population. So here are some triggers that can maybe trigger an ulcer, but again, we don't know what in the tissue is causing the ulcer. But you can have trauma, stress, spicy or acidic foods, sometimes associated with systemic disease. Aphthous ulcers is thought to have a pathogenesis from the immune system. So you can see this in 3 forms: minor aphthous ulcers, major aphthous ulcers, and herpetiform aphthous ulcers. Now, just some side notes is canker sores are aphthous ulcers, and they are different than cold sores or herpetic lesions. They're just a canker sore, because we know cold sores and herpes lesions come from viruses, right? Aphthous ulcers, we don't know where they come from. So non-smokers get canker sores more often than smokers, and people with a lot of money also have a higher chance of getting more canker sores. And if you ever are gonna remember a disease in the mouth due to the immune response, you need to remember aphthous ulcer, because it's the one you're gonna come across the most often. So remember, there's 3 types: minor, major, and herpetic. So minor aphthous ulcers. These are round or oval. They occur on movable mucosa. So that's why you see them on the lips, on the frenum, the tongue, on the lower base of the tongue sometimes. Anyway, they're less than 1 centimeter in diameter, so they're small, minor, and they have a red halo, erythematous halo, surrounding a white yellowish surface. So red with yellow, white in the middle. And they're most often in the anterior area of the mouth. Why is that? Because that's where most of our movable tissue is for our mouth. They may have single or multiple lesions, and they may have a prodromal period of 1 to 2 days. Okay, so there's a picture of it. Again, small, less than 1 centimeter, red halo ring, yellow in the middle. It can be oval or circular. And then you have major. Major is bigger than 1 centimeter, and it's also deeper, and it lasts longer than the minor ones. This is very painful. It occurs in the back of the mouth more often than the front. It may require several weeks to heal, and sometimes can even require a biopsy. So remember, major is in the back of the mouth on movable tissue, like the buccal cheeks, on the palate, all the way back there. And the difference between minor and major: minor is in the front of the mouth, major is in the back of the mouth. Minor is less than 1 centimeter, major is more than 1 centimeter. There's another picture of it, and remember, it's super deep. Owie. Okay, herpetiform aphthous ulcers. These are tiny, tiny little aphthous ulcers, 1 to 2 millimeters, and they look a lot like herpes simplex ulcers. But remember, they're not, because they don't come from a virus. We don't know why they come. They're painful, and they generally occur in groups. So it's important to remember not to mix these up with herpetic lesions. These are just canker sores that group together. And a way to figure out if it's a minor aphthous ulcer is you look at the clinical appearance and location. Remember, we talked about minor aphthous ulcers are on movable tissue, and they do not produce systemic signs or symptoms, but herpetic lesions do. So that's one way you can tell a difference. Herpetic lesions will produce specific systemic signs. Also, ulcers from the beginning do not start as vesicles, whereas herpetic lesions do. So here's even more information between, is it herpes or is it ulcers? Aphthous ulcers are on non-keratinized tissue or movable tissue, because remember, if your mucosa is movable, it's non-keratinized, it's not thick. Aphthous ulcers develop individually or several at a time if they're the herpetic form. There's no vesicles. They don't start out as vesicles. And aphthous ulcers are typically larger. Even though herpetic lesions can group together and make a large lesion, aphthous ulcers individually on their own are typically larger. So, how do you treat minor aphthous ulcers? So the minor ones, again, are small, front of the mouth, movable tissue. You can treat them with over-the-counter medication, such as Orabase or Zerlactin. You can use topical or systemic steroids or topical anesthetic. Alright, and now you have urticaria, hives. These appear as multiple areas of well-demarcated swelling of skin. You may have itchiness or pruritus. Lesions, hive lesions are caused by localized areas of vascular permeability. It's a common reaction to an ingested allergen. Angioedema, lesions caused by diffuse swelling due to increased permeability of blood vessels. So the skin covering the swelling appears normal, and it usually does not have itching. So urticaria is itchy, angioedema is not itchy. Fixed drug eruptions. Fixed drug eruptions is a type 3 hypersensitivity reaction. It's the inflammatory response of the immune system. Localized reaction is the result of systemic exposure to a drug. So basically, when someone has an allergy to a drug, they get the same response every time. And if it's in the mouth, they get the oral lesion in the same place every time. So here's examples of them from drugs. You can have drug reactions. Okay, erythema multiforme. We don't know the cause of it, but it's a hypersensitive reaction, occurs mostly in young adults, and occurs more often in men than women. It targets lesions. Its lesions look like targets. They have a red ring and a yellow-white center. The skin lesions can range from macules to papules to bullae. So they could be flat, they can be raised, and they can also have fluid filled in them. In the mouth, they're usually seen as ulcers. They're seen on the lateral borders of the tongue, crusted and bleeding lips. Gingival involvement is rare, though. You usually don't see it on the gingiva. And you can have chronic or quick-acting acute episodes. So how do you diagnose that? Diagnosing erythema multiforme is based on the clinical features and by exclusion of other diseases. So if you see it on the skin and you can exclude other chances of disease, then you know that's probably how it is. Treatment and prognosis. You basically need topical or systemic steroids. There's a picture. Again, you can see it's all shapes and sizes, but they look like targets. A red ring and a yellow center. There it is in the mouth. Crusted lips, etc. Lichen planus. Lichen planus. It's benign. It's a chronic disease affecting skin and oral mucosa. Again, it's unknown because all of these are unknown. Lesions have characteristic Whitcomb striae. The lesions can be on the tongue, lips, floor of the mouth, and gingiva. And they present in about 1% of the U.S. population, mostly common in middle-aged people. Slightly more common in women in chronic disease. So there's two types of lichen planus. There's reticular lichen planus, which is the most common form. So what's the most common form? Reticular. What's the most common form? Reticular lichen planus. And then you have erosive and bullous lichen planus. And in this situation, epithelium separates from connective tissue, creating like a big blister. Desquamative gingivitis can be caused by lichen planus. Skin lesions. If you see it on the skin, it's going to be 2 to 4 millimeter papules, commonly in the lumbar region, in the flexor surfaces of the wrist, and then the front of the ankle. And you need to have a biopsy for the for sure definitive diagnosis. So how do you treat lichen planus? You only treat it when it's symptomatic. You can have regular oral examinations and biopsy the lesions when necessary. And the patient may be at risk for development of squamous cell carcinoma, which is cancers. So here it is in the mouth, lichen planus. It can look like little white patches or little white lines. It's hard to, like spiderwebby kind of lines. Anyway, so that was all oral diseases in the oral cavity. So now we have autoimmune diseases that affect the oral cavity. So autoimmune disease is systemic in the body, but these can have a side effect that affect the oral cavity. So that's the difference between these two groups. So you can have Sjögren's syndrome, which affects salivary and lacrimal glands. It results in decreased saliva. It may be associated with other autoimmune disorders. A primary Sjögren's syndrome occurs alone, and secondary occurs with other autoimmune diseases. Patient may complain of oral discomfort due to dry mouth. So basically you lose the filiform and fungiform papillae on the top of your tongue. So Sjögren's syndrome, dry mouth. How do you diagnose it? Well, if you see xerostomia, you measure the saliva and biopsy to see. And also you can have keratoconjunctivitis sicca, which is confirmed with an eye exam. I think it has to do with your eyes. Or rheumatoid arthritis. So basically, you know you have Sjögren's syndrome when one of these three things is also present: xerostomia, keratoconjunctivitis, and rheumatoid arthritis. The course of the disease is chronic and benign, but these patients are also at risk of developing more serious diseases. How do you treat it? NSAIDs for arthritis, may need corticosteroids and immunosuppressive drugs. For saliva and xerostomia, you need humidifiers, sugarless gum, pilocarpine, because we know pilocarpine helps to bring xerostomia away. And you can have glasses or artificial tears to protect your eyes from eye dryness. So the Raynaud phenomenon in regards to the Sjögren's syndrome. Raynaud phenomenon. So 20 of these patients will have this disorder affecting fingers and toes. You have pallor and subsequent cyanosis of skin due to cold or stress, which is the turning purple, or hyperemia when blood vessels are warmed. There's a picture. Alright, and then you can have lupus. Lupus is acute and inflammatory autoimmune disease, doesn't have a cause, affects women more often than men, and more often in black women than white women. You have skin lesions in 85% of the people. It's a butterfly rash on the ridge of the nose. It can be red looking and can also have lesions on the fingers, and arthritis is common in these individuals. And you can have oral lesions also in about 25%. So on the fingers, on the nose, a butterfly shape, lupus. Pemphigus vulgaris. This is a severe progressive autoimmune disease that affects skin and mucous membranes. You can have acantholysis and T-ZAC cells, which are genetic and ethnic factors. T-ZAC cells get in between the epithelial cells and cause a blistering, which helps the epithelial tissue to lift off from the connective tissue. Pemphigus vulgaris is an oral lesion, and the first sign of disease is in the oral cavity more than 50%. If you rub the skin with your finger, you can cause a bullous. So these people need corticosteroids, and they have a mortality rate of 8 to 10%, so they typically do not survive. And there it is in the mouth. And then you can have mucous membrane pemphigoid. which is a chronic autoimmune disease, affects oral mucosa, not as severe as pemphigus, so pemphigus is more severe, and gingival lesions have been called to desquamatize gingivitis. May be seen with lichen planus and pemphigus as well. How do you treat mucous membrane pemphigoid? You need to have corticosteroids or systemic steroids. So there it is in the mouth, mucous membrane pemphigoid. And then you can have a bullous pemphigoid. 80% from patients older than 60. And oral lesions are less common. And you, again, treat them with corticosteroids and NSAIDs. There you go.